Well, it's 7:15 and I'm going to go ahead and get started. I'm really grateful to have this chance to spend some time with you, and I hope that it will be fruitful for you. Please, as we go along, don't hesitate to either unmute yourself and ask a question or put a question in the chat, and we will definitely get to that as we go through the cases today. We're going to talk about the mediastinum. And I think I'll stop the share here to share a different screen. As you think about that, I know this is not the most common area for surgical pathology, but it's certainly one that can be very confusing and challenging to us. So first, just to sort of review the normal histology of the thymus. As you know, this changes over the course of adulthood and maturing. In youth and early adolescence, we have a fairly cellular organ with a lot of blue cells, and that can include some sort of terminal center-like structures, as you see here, where you have sort of follicle-type patterns. The hallmark, of course, of the thymus is the presence of the so-called Hassel's corpuscles. Now, these are not named after me, although I've had several people ask me that, but these are small little nests of spheroid epithelial cells that sometimes have a little bit of a keratinization appearance to them. And if you find them, you can be virtually certain you are in the thymus. They are the hallmark trait that is found in no other organ of this sort. Now, as we mature and our immune systems develop, the thymus, of course, seems to have done its job. It looks like I forgot to relog in here. Let's come back in. And those normal T lymphocytes have migrated out of the thymus to the rest of the body to perform their functions there. And so the thymus can look like this, with just here the very barest number of lymphoid elements and maybe a few little remnants of a Hassel's corpuscles. Sometimes they will calcify, so you may just have a little bit of calcific debris remaining. But this is a totally involuted thymus with, as you can see here, a few occasional other structures, small duct-like structures. There can be variable amounts of other epithelial structures in the thymic area because of the embryology and the potential for implants of other brachial cleft or brachial pouch remnants to persist in this area. And that actually will bring us here to our, I should also mention that thymic hyperplasia can occur as well, in which you essentially lose all of the fatty tissue and you have a complete diffuse lobulated lymphoid organ, as you see here, with an abundance of lymphocytes and no fatty tissue remaining here. So that also is in the differential. That may be more common with patients with myasthenia gravis, just as thymomas can be more common in patients with myasthenia gravis. Okay, so one of the unexpected findings in the thymus sometimes are other brachial cleft vestigial lesions. I mentioned those ductal elements we just saw. But another possibility is that you actually have ectopic thyroid or ectopic parathyroid tissue. And actually, in this case, there's a little clue over here. You see this eosinophilic tumor, very rich here, adjacent to the thymus. And the clue as to what this is lies right here, as we see these more recognizable parathyroid type tissues with the adjacent very oxophilic elements that are indicative, in this case, of a parathyroid adenoma. Now, most head and neck surgeons will know, of course, where in the thymus these are likely to be located, but they can be difficult surgically, and there's certainly more than one occasion, especially because parathyroid lesions can be quite small, that they'll localize several glands in the neck and not find the target adenoma, and therefore they need to go looking further into the mediastinum. And so this is a nice example of a parathyroid adenoma, as you can see, very enlarged, very monotypic in sense of very oxophilic cells with a few small follicle structures that is occurring in the thymus. And based on the cellularity in this thymus, you might suspect that this is not a child, but also not quite an adult with a completely involuted thymus. Another possibility in the thymus, of course, is that you develop what's called a thymolipoma. And in that case, you may again have very limited or minimal residual thymic tissue and just a replacement by fat. This is very much a disorder where you need to be very suspect of little areas like this as being small thymic remnants. Here we don't see a Hassel's corpuscle per se, although there may be a little bit of an epithelioid appearance here that would be characterized by thymic epithelium. And so cytokeratin stains in a situation like this might help you to delineate that there are some cytokeratin positive cells here in this lesion that otherwise is just pure fat, and therefore help you to identify this as a thymic lipoma. Here again, over here, you can see a few additional thymic remnants, very, very vestigial, very, very small amount of tissue remaining. So those are some of the benign lesions that we can see in the thymus per se. In the mediastinum, we also have, of course, other embryologic and developmental defects that are going on. And that can include the development or presence of cystic structures. Now, cystic structures within the thymus can be either primary thymic origin. They can be related to Hodgkin's disease. That was one of the first papers I published was about thymic cysts in Hodgkin's disease. And they can be this type of cyst, which as you see here has a more columnar type lining. And I think we can come in here and you can imagine that there's some cilia here. You can see a few terminal bars. And so this is ciliated respiratory type epithelium, and that helps to define this lesion as a bronchogenic cyst. As you can see, there's no cartilage, but there can be variable amounts of cartilage and adnexal glandular tissue that can develop in these as well. It just depends upon how much of that embryologic remnant has become associated with that. Here's a little listing of some of the other kind of cystic structures that you can see in the mediastinum. We've mentioned these. You can also have ectopic pancreas. You can have parathyroid type lesions or thyroid lesions that develop cystic structures. And if we mentioned both those that are associated with Thymoma and Hodgkin's disease. So that's a pretty lengthy differential for those mediastinal cysts. Okay, so let's get on into another disorder. This is, as you can see, sort of a fragmented biopsy here of an apparent mediastinal mass with ill-defined borders. And perhaps if you're doing PET scanning, some increased avidity to the tracer. And as we come into higher magnification here, you can see that it's not an epithelial structure, but rather what we're seeing is a predominance of maybe histiocytoid cells, moderate to abundant eosinophilic cytoplasm. There's some admixed lymphocytes in here. A few eosinophils can be identified. As we look a little further, it's It's got a little bit of a collagenous appearance to it, maybe developing that. And there may be some plasma cells. I can't go to any higher magnification here, but I think some of these cells were also plasmacytoid. So what does this represent? Some sort of a funny inflammatory process. Um, it doesn't look like lymphoma, although you'd certainly want to include that in your differential. Sarcoidosis might also enter the consideration, although it's not really very tightly granulomatous in the sense that sarcoid granulomas appear in that way. So does anybody know what this entity is off the top of your head? Well, this is what's termed sclerosing mediastinitis. There are some similar disorders that can occur in the intra-abdominal mesentery, as well as some other disorders in other organs that can have a similar appearance with this fibrotic background with a mixture of inflammatory cells. You might think of inflammatory myofibroblastic tumor in the differential. That's really quite uncommon in the mediastinum, whereas this is a little bit more common. This is also a disorder that is sometimes, not always, associated with IgG4 excess. And so in certain cases, doing immunohistochemistry to subtype the plasma cells here to see what your proportion is of IgG4 positive cells versus other cells. Alternatively, sometimes peripheral blood evaluation can give you that information as well. And the significance of that, of course, is that IgG4 related disease is more likely to then recur in other locations, sclerosing cholangitis, autoimmune pancreatitis like masses, Kuttner's tumor of the submandibular gland, those kinds of areas. And those are significant because they can be treated without surgery, treated by means of immunosuppression, steroid therapy, et cetera. And so this is an important diagnosis to make. Ideally, you don't have to do an invasive biopsy like this, but could make the diagnosis using perhaps a needle core. Cytology might be a little bit more difficult, but certainly a needle core biopsy should enable you to suggest this possibility as well. So this is a nice example of sclerosing mediastinitis. And of course, I'll give you the link to these digital slides so that you can come back and look at these yourself. This is usually adults that are presented with this. They may have some degree of phlebitis, and the inflammatory infiltrate, very fibrotic, rich plasma cell eosinophilic infiltrate. Okay. Well, I mentioned that sarcoidosis was in the differential. I thought I should at least put a slide in here that was a good example of that. I know this is maybe not the most common disorder in the mediastinum, much more frequently encountered in the lung. But because mediastinal lymph nodes can often be involved and can raise concern for malignancy and so forth, they may be the ones that are biopsied. And so an awareness of what sarcoidosis looks like is, of course, important. Here you see these very nice, rounded, and quite tight non-necrotizing granulomas. There may be occasional giant cells in these granulomas, and there, of course, are other features like asteroid bodies and so forth, which can be seen but are not always present. And I looked quite a bit here and I could not find any. But we do have the nice non-caseating, non-necrotizing granulomas here in the lymph node that are obviously effacing the entire lymph node architecture in this particular case. Now, of course, you're going to have to do stains because you can't reliably diagnose sarcoidosis unless you've excluded other possibilities. And I would include in that the possibility that you are dealing with a pneumoconiosis. In other words, patients who are exposed to silicates, either through hard rock mining or through various industrial exposures, can also develop a hyalinizing granulomatous-like lymph node appearance. And those are cases where doing polarized light exam can be very instructive. It's a very cheap and simple way to do it, or a simple way to examine these nodes, looking for the foreign material. Now, here's a little bit of a foreign material here. This is not a silicate. Silicates are usually kind of rhomboidal, small crystals of less than a micron in size, and they will light up using polarized light exam. So get some polarized sunglasses and poke the lenses out and put one above the slide, one under the light source, and you should be able to identify them using that very simple technique on your microscope. All right. Well, no self-respecting surgical pathologist can ignore neuroendocrine tumors, and the mediastinum, of course, has its share. Typically, these are associated with things like the aortic body or the carotid body and so forth, and come in the form of a paraganglioma, which is, in fact, what this case is, but a nice illustration of the packeting of these cells into small nests and packets. In paragangliomas, you sometimes get a little bit of a spindle-shaped appearance, but you don't have that always. You can see here the nice neuroendocrine nuclear features, sort of salt and pepper chromatin, moderate to abundant cytoplasm, and quite a vascular structure here, as you see all of these small vessels coursing through here with red cells and so forth. So you can certainly identify these using neuroendocrine stains. You may opt to do also an S100 stain to try to identify the sustentacular cells that surround these bodies, and may not be evident here on H&E, but could be identified using immunohistochemical techniques. Of course, the anatomy is important. If you're thinking about a carotid body tumor or an aortic arch tumor, this is the location where these lesions will occur. And the surgeon, if he's wise, will help you out with by giving you that location for this lesion. Okay, well, finally, we come on to the neoplasms in the thymus. And we'll spend the bulk of the rest of the time talking about these lesions with a few others of the differential consideration. But here at low magnification, this illustrates some of the things you should be seeing. Dense fibrous bands are a hallmark of thymoma, and this is no exception. These are very accentuated fibrotic bands surrounding this tumor. You want to, of course, look to evaluate your margins and see what you have. And in fact, over here, it looks as though we have some remnants of normal thymus over here. I think we can see, yes, here I think you can see there's some Hassel's corpuscles here. And that's helpful because that says to you that this is normal thymus rather than an alternative component of the thymoma. So normal thymus on the periphery helps you to define here the boundary of the neoplastic cells. Now, thymic tumors come in a variety of morphologies that can include variable numbers of lymphoid elements. Here in this area, there's quite a bit of edema. The lymphoid elements are quite sparse, and it's mostly the thymic epithelial cells that you see here forming the tumor. Elsewhere, we may get a little bit more of the lymphoid elements, as you see here, a few more scattered in amongst these cells. And really the key differentiator between type A and type B neoplasms is not so much the number of lymphoid cells associated with this tumor, but the shaping of the shape of the cells. So here we see that these cells have really more of a polygonal or spindle-shaped appearance that is more characteristic of the type A thymomas. And that is an important consideration to look for that cellular morphology. Now, occasionally they can get these actually lining up, almost forming a pseudo-glandular type of appearance. Here, there's a little bit of accentuation around these cystic spaces. Here you see a little bit of lining up around here. So it can almost develop a pseudo-glandular appearance as well. I don't think you'd have much difficulty in defining this as a neoplasm. And that's really the important thing because, as we'll see in a minute, the behavior depends not so much on whether it's A, B1, AB, etc., but on the margins, on the extent of the lesion, and so forth. So I want to emphasize that again, and I'll highlight that with a slide here in a minute. In some nomenclatures, and I use the classification systems from a variety of sources. I know in most instances we're still going to use the WHO classification, which was updated in 2021, and so forth, and has a variety of types: A, AB, B1, B2, B3, and so forth, and type C. But in reality, these all have a potentially malignant character. There are instances where they can become invasive, they can become life-threatening. And so the term well-differentiated thymic carcinoma may be analogous, if you will, to the type of classification we use with differentiated thyroid tumors, for example. We have thyroid well-differentiated thyroid tumors that have papillary architecture. We have well-differentiated thyroid tumors that have follicular architecture. But at the end of the day, the behavior is not terribly different between these two entities. Their risk of progression in the patient is somewhat defined, and we can usually anticipate good outcomes. And the same is true of these thymic lesions. Now, the Thymoma B2 can have an abundance of a mixture of T cells or moderate numbers, but the cells are more polygonal. And so, we might go back to this case and say, well, is this a B2 or is this an A1 type of lesion? Because, in some areas it's a little bit more polygonal. In other areas, we saw a little bit more spindle shape. Well, the bottom line is it's not going to make a whole lot of difference. And so understanding that the treatment, the prognosis are not so much dependent on whether you get the letter right as much as the fact that you recognize that it's thymoma, that it's a well-differentiated type, and that it is, and you define for them the margins and the size and extent of the tumor. Those are the factors that are going to play into the evaluation of the case. Well, what's going on here? Hit the wrong button. Okay, so here's the WHO classification. Spindle epithelial cells. We don't use this term spindle cell thymoma or medullary thymoma. We just use type A. And the type B cells are more polygonal or rounded. And those come in 1, 2, and 3. And then type C is when you have a frankly malignant. So this is a more poorly differentiated, but in reality, both type A and type B are really well-differentiated thymic carcinomas. All right, so let's go on to another case. Here's another example. We have very dense fibrous tissue here. not quite clear if this is residual thymus that's been involuted. And then we have here another thymic neoplasm that is predominantly epithelioid cells, very few other neoplastic cells here. And so this might be, again, a well-differentiated thymic neoplasm with those features that we've described, and very few lymphocytes involved in this lesion, hardly any that we can recognize here. And so we might classify this as thymic neoplasm type A, which, as you can see here, can have these small follicular structures, well-defined bland spindle cells. And the important thing here is that this is more frequently associated with myasthenia gravis, and it may have occasional areas like, as you can see here, sort of glandular formation, which we've talked about. All right, let's take another example here. This one is quite different. As you can see here, we have over here an area of residual normal thymus. You can see the infamous Hassel's corpuscles here. There they are, beautiful structures. And then we have this element over here, which looks to be totally lymphoid. As you can see here, it's very blue. And we really have difficulty picking out of here any degree of epithelial component. There are a few cells here like these that we might be thinking of as possibly epithelial, but they could be histiocytes and so forth. So our differential would include the possibility of, low-grade lymphoproliferative disorders, like well-differentiated lymphocytic lymphoma and so forth. And that's certainly worth excluding. But in your immunophenotype panel for this, you certainly should include a cytokeratin stain that will be able to highlight the presence in here of thymic epithelium. And in fact, that's what this is. This is a nice example of a B1 lesion with a very nice abundant lymphoid infiltrate. And as we can see from the margins here, this is fairly well circumscribed. It does not have an invasive character, although we might wonder if this was a true margin here. So inking these specimens is going to be important as well. So I mentioned and classified this as Thymoma B1. Bottom line, very hard to recognize the epithelial elements in these B1 lesions. You still may get some degree of fibrous banding in these lesions, and you may have almost germinal center-like areas, as you see here in this area. Here's another slide showing you the very lymphoid-appearing predominance of these lesions. Okay, here's another case, and here we see again a couple of different morphologies. We see this sieve-like pattern that we've seen already here in some of the previous cases, and this is a nice illustration of these pseudoglandular spaces. Here, notice how it really does look like you have an epithelial lining here with almost maybe cilia-type structures around some of these cystic structures. So is this a type A thymoma? Well, we might think of that as certainly a possibility here, certainly very predominantly epithelioid. But notice here we also have an area over here where this doesn't look like normal thymus. I apologize for the dirty slide here. And we've got a much higher admixture of lymphocytes here amidst the thymic epithelium. So as you can imagine, if you had a needle biopsy that was just this, you might call it a B2 or something like that, or maybe even a B1. Whereas if you had a biopsy that was just showing you this, you might classify it differently. Well, as we've indicated, that significance is not overwrought, is not a huge thing. Now, the other feature that's here that I wanted to highlight with this case is this cystic structures that are developing. And here you can see we have some old hemorrhage with cholesterol clefts, and we have these very delicate cystic structures with very thin walls and a lot of clear fluid. So this is where you can begin to imagine the thymic cyst type of lesions that can be associated with thymoma. And then here another area, slightly different mixture, less predominant epithelial, sort of a mixture one-to-one almost of lymphocytes and the more readily identifiable thymic epithelium. So as I indicated, the important thing is to recognize it as well-differentiated thymoma and not so much to worry about whether it's A, B, et cetera, et cetera. Okay, so here's another easily recognizable case of thymic neoplasm. As you see, there's no cystic structures here, but at low magnification, there's a couple of features that come out to us. One is how it's interfacing with the surrounding fatty tissue. Notice here there's areas where it's bulging into the fat, and here, actually down here, we have areas where this is clearly provoking a desmoplastic response in the fatty tissue, and therefore would be classified as having an invasive component invading the surrounding tissues. And that's a very helpful feature to define both risk of recurrence, metastasis, and long-term outcome. So irrespective of what kind of classification system or what class you put it in, A, B, et cetera, defining this area of invasion of the fatty tissue is very useful. Now, you may still have here's maybe a little remnant of normal thymus. Maybe this is a little bit of a Hassel's corpuscle here with normal surrounding thymic T cells. Another feature that we see here is, again, this variable morphology. Notice here we can have some hypereosinophilic cells, more oncocytic type of appearance of the epithelial cells, an admixture, of lymphocytes. And then over here, I think it's a nice juxtaposition. Let's see if we can find it. Oh, there it is. Okay. Right here. So this would be a nice example if you had an abundance of this of type AB, where you have the purely epithelioid component juxtaposed with a more lymphocyte predominant area that would also have thymic epithelium. So if I were to take a picture like this and say, okay, this is Thymoma AB, and put it in a textbook, no one would dispute that. This is virtually pathognomonic of that appearance. But the problem with that is, of course, this is not the majority of the neoplasm. Yes, we have some B areas, we have some more A-type areas, but the majority of this is this. And so sampling and so forth can make a difference in your classification and which title it gets. But the bottom line should be that's not as critical as the staging, the information about size, extent, extension into surrounding tissues, and so forth. So thymic carcinoma, Thymoma AB has lymphocyte poor areas and lymphocyte rich areas. This is fairly common. and has some association with myasthenia gravis. There's no specific designation as to how much of this lymphocyte-rich versus lymphocyte-poor area you have to have to call it that. I think any significant or appreciable amount would classify. So this previous case, I think, has enough of the lymphocyte-rich areas like here. So maybe this is 4 or 5% of the tumor, as opposed to the 90% of lymphocyte-poor areas. It could still be called Thymoma AB and be correct. Oops, let's see, didn't do that. Now, I haven't shown you an example of the more higher grade B3, which has more cytologic atypia. And we also have in the new WHO the atypical Thymoma AB. These tend to be more locally aggressive and therefore unresectable in more cases, and would really fall into that category of more moderately differentiated thymic carcinoma on other people's classification. In other words, we're trying to tell you that the B3 or moderately differentiated tumors are more likely to have a poor outcome relative to that. And so here's the sort of contrasting these classification systems, several of them dating back into the early, before the lifetime of most of you. You can see Saul Schuster and Cesar Moran are the ones who came up with well-differentiated thymoma and grouped all of these together, A, B, B1, B2, and so forth. And then only drew the line here at B3 and type C. And the reasoning behind that is highlighted in these prognostic categories, which can include all of these 4 types with very good outcomes. The group 2s, which have a little bit more aggressive outcome, but maybe if they're completely excised would be in risk group 2, and any of these others which are widely invasive. Now, if we look at, instead, I'm just going to skip over this. If we look at the survival curves, I think you can see why this makes some sense. Because here in reality, if we group all of these low-grade, well-differentiated types, in other words, from Schuster and Moran, they have 90% survival at more than 10 years. And whereas B3s and type Cs are going to have more dire prognoses. So that's kind of the biologic behavioral thinking behind the terminology that I gave you. Now, obviously, we use the WHO to communicate more accurately and so forth. But as I've indicated, in terms of patient outcome, in terms of patient management, it's really these other issues that are going to make the difference. How widely resectable it is, whether or not it's invasive or they're distant metastases and so forth. Those are going to be the outcomes in these risk groupings. Okay, so resection here, also illustrated here in this curve, that 5-year survival, if that's incompletely resected, only 9 or 10%, maybe 15%, versus 80 or 90%. So resectability is really critical. And that's where your evaluation of margins is very important, as well as communicating with the surgeon about these elements. Okay, in the last couple of minutes, let's move on to a couple of other neoplasms. Certainly no discussion of the mediastinum would be complete without mention of other neuroendocrine tumors. We've mentioned paragangliomas, but we also can have primary neuroendocrine lesions in the thymus and mediastinum, which would classify as carcinoid tumors. Now, actually, in the WHO classification, they still use those terms, albeit there is a recognition that we're trying to move away from that so that we have a body-wide, systemic-wide, uniform classification for these neuroendocrine tumors that is based on morphology, proliferation rates, and so forth. No difficulty, of course, in recognizing this as a well-differentiated neuroendocrine tumor, which in the thymus, mediastinum is still called a carcinoid tumor. Atypical carcinoids are those with obviously more worrisome features, maybe areas of necrosis, maybe increased mitotic or Ki67 indices and so forth that would move them into the atypical carcinoid category, or what we would term in other areas the well-differentiated tumors type grade 2 or grade 3. I think at this point, if I were you, I would be reporting these with dual mention of those classifications based on the conventional body versus the mediastinal classification system. Okay, here is another lesion and one that we should mention in the mediastinum, although it is most commonly seen in other areas. We do see it happening in the mediastinum. This is obviously a very high-grade neoplasm. As you can see, there's a lot of prominent nucleoli, a very undifferentiated appearance, this sort of amphiphilic cytoplasm, and so forth. A very high-grade, undifferentiated carcinoma. So this lesion can occur as just a high-grade lesion, and you may not suspect the diagnosis if you don't have one of the little clues that we look for, which is located here, I believe, down here. Right here. So here we see undifferentiated tumor immediately juxtaposed with an area of fairly well-differentiated keratinization. And this is characteristic of a particular mutation-derived tumor. And if anybody knows that tumor, you can certainly type that into your chat to sort of walk off with it before I give away the answer. But this feature, this appearance of finding undifferentiated tumor with very abrupt microfoci of keratinization is typical of the NUT carcinomas. And in as much as there's now a defined immunohistochemistry, we don't have to rely on the mutational analysis. We can, if we have brought that antibody into our repertoire, we can use that to help define this lesion because it will quite nicely demonstrate that in these tumors. But if you're just looking at the undifferentiated tumor, you only have a small biopsy, that's when the immunohistochemistry may be particularly useful in helping to define that if you don't have a good sample that includes these little foci, as we've indicated here. So nut carcinoma, this is not a tumor that is very common, but it's certainly one to be aware of because treatment's going to be quite different than if you're thinking lymphoma or other undifferentiated malignant tumors in this case. Okay, another lesion that can have a very deceptive and variable appearance is this. Although clinically this is usually not a big issue, it usually presents involving the pleura, but it may invade the mediastinum and thus show up in that kind of a biopsy. So this is a nice example, and I'll let you study this at your leisure later on, of a malignant mesothelioma. This one with a predominantly epithelial or epithelioid appearance, forming these little micropapillae rounding up and invading with some slit-like spaces between the formations here. Notice these little slit-like patterns here. Very much like some of the slit-like things we see in micropapillary lesions in the GYN tract. Of course, everything has some resemblance to the GYN tract. So a nice example of epithelioid mesothelioma. But recognize here that this also includes this area here, which gives you some additional morphologic features that you might see in a more spindle-shaped mesothelioma. These cells also will be immunoreactive with calretinin. And then here's another area of more sarcomatoid appearing tumor. So a biphasic tumor at times to variable degrees that has mesothelial differentiation. And then some other lesions that can occur in this area, liposarcomas, usually not the well-differentiated type, but more typically the round cell type of myxoid liposarcoma that may have a predominance of lipoblast. I think you can find a few here if you come back later and take a look at this lesion. I think you'll find some cells like this that have reasonably good lipoblastic character. This is a lesion to consider as well. Very uncommon. Another uncommon neoplasm in this location would be synovial sarcoma, but certainly not beyond consideration. And as you can see here, a monophasic synovial sarcoma may look a little bit like a solitary fibrous tumor. It doesn't have some of the other features that you tend to associate with solitary fibrous tumor, like the wiry collagen, the staghorn vessels, and so forth. But it certainly can have a very monotypic spindle-shaped cell morphology. Very cellular, more cellular than, say, a desmoid tumor would be, or other lower grade neoplasms. Of course, anytime you have a fairly monomorphic sarcomatous lesion, you do want to think about the possibility that you're dealing with some sort of a fusion gene related sarcoma, and that certainly is the case with synovial sarcoma. Now, we do have the SSYT immunohistochemistry available now, or if you're able to do the FISH testing, that also can be diagnostic for this lesion. And I believe this is an example of a solitary. Well, let's see. No, this is another lesion. This actually was a cardiac lesion. As you can see, it's quite epithelioid appearing. It has very much that undifferentiated appearance, anaplastic appearance. And this is another entity that can occur in the mediastinum. This actually, I think, was primary in the cardiac muscle and pericardial tissues. This is an example of a high-grade epithelioid angiosarcoma. And you wouldn't always suspect that in these more solid areas because you don't always have a really strong area of interstitial red cells to raise that suspicion. But certainly any high-grade epithelioid tumor in the mediastinum, you do want to consider angiosarcoma. Of course, this appearance around the vessels here is helpful in defining that as well. Okay, I think we're getting down to the end here. This is our last case. This is the solitary fibrous tumor, just for sort of completeness sake here. So at this point, I'll pause and take questions. If any of you want to pipe up with questions, I see there's a comment in the chat here. Let's just take a look at that. Oh, very good, Spani. Very good. As expected, you're sharp. Any other questions from anyone?
Yeah, Dr. Hassel, I have a few questions. So the first one is regarding the resection in thymoma. When do you call it an R0 and an R1? Is there a safe margin, for example, a few millimeters, or as long as it doesn't touch the ink, we call it R0?
Yeah, that's a good question. I haven't done a lot of these in the thymus or that area. And so I think the best analogy for me would be how we make that decision in the pancreas, because I have more experience there. And anytime you're, within a millimeter of that margin in the pancreas, I think we still call that an R1, irrespective of whether we actually have tumor on ink. If we have tumor close to cautery or anything like that, I think it's best to consider that an R1 rather than an R0.
I see.
Good question, though. Good question, though. And this is kind of where I think you, as pathologists, have a great opportunity to influence therapy and care of your patients. Because as you evaluate these specimens, and I know I always think, well, if this were my mother, would I want her to get more treatment or something like that? Those kind of questions, asking yourself that issue, I think can give you a better handle on how to communicate that to your surgical colleagues or the oncologists who are treating these patients more directly. We certainly know that management of a suspect margin has changed considerably over the last few years, so that now localized radiation therapies or other considerations are certainly quite feasible and much less morbid than they were at one time. So I don't feel a great pang of guilt if I say, well, it's close. I think it'd be best to err on the side of caution here and call it an R1.
Okay, thank you. I was asked, I think a few weeks back for a patient that has a resected thymoma, but since it was, I think, a B2 or something like that, so it's there's no invasion to the fatty tissue, and I think 1 millimeter should be okay. So they just asked, and then they want to do the adjuvant therapy, the RT, the radiotherapy, and I think in this case, to me, I think it's more of the complications rather than the treatment itself. So I think maybe observations, but I let them
Yeah.
discuss among themselves.
Yeah, and of course, part of the also the consideration there is, how morbid is further surgery and those kinds of things. We don't you managing a recurrence obviously is not something that an oncologist or a surgeon wants to have to deal with. So their inclination is to err on the side of, sterilize that. Whereas from our perspective, we're more aware and we see some of those complications and the morbidities that come with too much therapy sometimes.
Mm-hmm. Dr. Hassel, for the carcinoid tumor, do you sign out as a typical carcinoid in biopsy? Because I think in the mediastinum, there's no clear guideline as in the lung biopsy. In the lung biopsy, I think we are not allowed to sign out as a typical carcinoid.
So I think you have to provide the information that you can provide. So if you see an area of, or you see an elevated Ki-67 labeling index, you need to report that. If you choose not to grade it or call it atypical or whatever, at least you have to communicate that there's greater than expected labeling. Now we know that in neuroendocrine tumors, there are hot spots, there are cold spots, and so forth. So in a biopsy sample, we may not get the hottest spot, and so that's the justification to refrain from calling it atypical carcinoid, or just to call it a neuroendocrine tumor. But I think you still have to communicate what information you've gotten about that, and that can steer them in terms of further management.
If it is clearly it is a typical carcinoid, I would sign out so. But if the low mitotic count there's no necrosis, I would tend to not call it a
Yeah.
as a simple typical carcinoid.
Yeah, your inclination there is, I think, just right. All
One
right.
last
Well,
question.
it's been great. One more question. Okay.
Yeah, just one last question. Because the last WHO classification is a bit confusing in terms of call, for example, the type 3 thymoma, B3, I'm sorry, B3 thymoma with anaplasia, and then another entity, they call it a thymic carcinoma. I think the differentiation between these two is just the positivity of CD5 or CD117. Do you usually do that in your practice?
So I would say yes, we would do those immunohistochemical stains. I mean, thymoma is so rare in our institution that it's essentially one or two cases a year in our institution. So I don't think we've encountered one of those cases that I'm aware of. But we would attempt to follow the WHO. But again, the experience with it is quite limited in many institutions and so forth. So that's what WHO is trying to promote. And even as I was putting the slide presentation together, finding good thymic examples, good thymoma examples was pretty difficult. So, even in a large collection of cases where people are putting in their more interesting cases, I was fairly limited in what I could scrape together to show. So you have great questions. Keep reading.
Thank you.
All right. Well, thank you everybody for joining, and we will see you next time.
Bye.